Before I'd like to start my presentation, I'd like to thank the organizing committee for this wonderful opportunity to present today. As you've heard from my bio, I am a part of the melanoma research group here at ECU, and I work mostly in circulating tumor DNA. Just to give everybody a bit of a background, melanoma is an aggressive form of skin cancer, and while treatments such as BRAF and MEK targeted therapies, as well as anti-PD-1 and anti-CTLA-4 immunotherapies have revolutionized the management of late-stage melanoma patients. The varying modalities and treatment responses of patients really necessitate the identification of biomarkers that can aid in clinical decision-making. To this end, our group is looking at ctDNA as a potential liquid biopsy for melanoma. Now, our group has done a lot of work. I'd like to summarize some of the work we've done where we compared the mutational profile of the tissue and ctDNA, and we found great concordance of mutations found in tissue and the plasma of patients, suggesting that ctDNA is viable for capturing the molecular heterogeneity of tumors. Previously, we've also shown that ctDNA correlates very well with metabolic tumor burden and tumor volume as measured by imaging scans, particularly PET scans, and that it's able to capture that the disease burden of patients. Now, for this particular talk, I'd like to really highlight a study that was recently concluded in our lab. This study aimed to define the validity of ctDNA as a prognostic biomarker and as a surveillance biomarker, but in the context of real-world clinical practice, which is not, it's quite rare in the literature. And I'd like to acknowledge my PhD student, Gabriela Marcivella, who's done a lot of work on the results I'm presenting today. So for this particular results I'm presenting, we really conducted a tumor approach for ctDNA analysis. So a tumor-informed, I should say. We have a custom-made melanoma panel containing 900 loci of known to be mutated in melanoma. These panel was able to identify mutations in patients, at least 3 to 4 mutations that we can follow over time during the clinical course of the patient. Once we identify a mutational variant that we can use for ctDNA analysis, we then design custom assay for digital droplet PCR system to test the plasma samples of patients. And then we contrast our results to the clinical outcomes of patients, which we also archive. So first, I'd like to start with the validity of ctDNA as a prognostic biomarker. So in 2015, we've published a study to show that irrespective of treatment, baseline ctDNA levels or pre-treatment ctDNA levels is prognostic. We, again, expanded our cohort of study because initially we only had around 20 patients in that cohort. So we expanded our patient cohort and looked at what the rate of detection that we have in of ctDNA in our melanoma patients. So we actually segregated the patients according to their BRAF, NRAS, and other mutations that they might have. And this is because previously we've shown that promoter mutations such as TERT or DPH3, which is common in melanoma, tend to be underrepresented in ctDNA. However, despite the fact that we have a detection rate of 65% in this cohort of patients, mutations in the TERT was not a factor in this low detection rate. What's interesting, however, is that we observed that patients with visceral metastasis tend to have a readily detectable ctDNA in the plasma. They have the highest median ctDNA levels overall in comparison to patients with only lymph and lung involvement. What we can't detect, however, are in patients with only brain metastasis, there was no detectable ctDNA in the plasma, which is actually similar to what was observed in our lab and of others. However, we did, again, in this expanded cohort, looked at whether ctDNA remains to provide a prognostic information for melanoma patients. We broke down our cohort into patients that were receiving first-line immunotherapy or BRAF and MEK inhibitors, and those that received second-line immunotherapy alone. While we confirmed the prognostic value of ctDNA levels pre-treatment, at first line to be prognostic, with low patients having low ctDNA levels having longer progression-free survival. This is not the case in patients that had previously undergone BRAF and MEK inhibitors. This result was quite striking, so we validated our results in a cohort of melanoma patients from the Melanoma Institute Australia and the Peter MacCallum Institute in Melbourne. Again, we've shown that ctDNA levels during first-line treatment does provide a prognostic information, but at second line, that prognostic value is lost. So overall, it appears that ctDNA levels, while it has a prognostic value, it's quite context dependent and is more appropriate for patients that are treatment naive. And also perhaps that in patients that have undergone previous treatment, that treatment may have imposed changes to the biology of tumor cells that actually prevents or affects the shedding of ctDNA in the blood. That, of course, that hypothesis is currently being tried in our lab. Aside from that, we also looked at in patients with high disease burden and therefore high baseline ctDNA levels, whether an aggressive treatment would be more beneficial for these patients. In a cohort of patients that were treated with either combination of anti-PD-1 and anti-CTLA-4 immunotherapy versus anti-PD-1 monotherapy, we found a survival advantage to these treatment combinations in patients with high ctDNA levels at baseline, as you can see in these two graphs. So in addition to the fact that ctDNA can provide prognostic information, our quantification of ctDNA appears to be also useful for essentially selecting patients that are likely to benefit from an aggressive treatment combination. Now, as a surveillance biomarker, we actually broke this study into two parts. First, to define the ability of ctDNA to indicate treatment response, and secondly, the ability of ctDNA to indicate disease progression. Now, previously, we've shown that ctDNA levels, again, correlates with tumor burden, and the fact that when there's a reduction in tumor burden as a result of treatment response, we see that concordant decline in ctDNA levels. And when patients also show signs of disease progression, we see that increasing ctDNA levels as well. Now, for the initial studies we've done, it's mostly anecdotal, and we really wanted to see whether the viability of ctDNA as a surveillance biomarker still holds in these large real-world clinical cohort. So initially we looked at the difference in the velocity of ctDNA decline in patients that received immunotherapy and targeted therapy. We found that the decay of ctDNA in patients that responded to treatment was very different, and in fact much slower in the immunotherapy cohort. We've seen that in patients, the decline in ctDNA levels as a sign of treatment response occurs only within the 12-week mark of treatment. This is longer in comparison to the patients that received targeted therapy, where ctDNA decline occurred within the 6-week mark. The slow decline in ctDNA levels in patients treated with immunotherapy is likely reflective of the lag of time necessary to really mount a huge immune response to fight the tumor. Aside from that, we've also noticed that in patients that responded to treatment and either had no detectable ctDNA from the beginning and within that 12-week monitoring period, or if they had a detectable ctDNA pre-treatment but declined, ctDNA declined within 12 weeks, we see a survival advantage in these patients. So there's longer progression-free survival in patients that had either baseline negative and continues to be negative or decline within 12 weeks of treatment. And this is true for both immunotherapy and BRAF and MEK. So yes, I think this is likely where I stopped. So as I said previously, we have shown that ctDNA levels does correlate with clinical response. The work that we've published earlier is while it gives evidence that ctDNA is able to indicate response to treatments, it was anecdotal. And for this big study that I'm now presenting, it's really a cross-sectional study to define the ability of ctDNA as a surveillance biomarker in a larger cohort of patients. So I've previously indicated the ability of ctDNA to indicate response. I've gone through these slides before, and that there's, as in patients where ctDNA was undetectable in the beginning or they had declined within 12 weeks, they had a overall, it's predictive of response to treatment and overall advantage in survival. However, when we looked at our detection rate at PD to indicate the ability of ctDNA to indicate PD, our detection rate overall was around 62%, which is not very far off to our baseline or pre-treatment detection rate. What's interesting though, in patients that where we had samples taken at the time of response and progression, we are able to observe an increase in ctDNA levels at the time of PD relative to the point of response. Now, we tried to employ a standardization method to see whether we can have a statistical measure to say that there is indeed a significant increase in ctDNA. When we employ a Poisson test, however, only 35% of cases had a statistically significant increase in ctDNA. A major roadblock to this also is that in patients where with disease progression in the brain, we're unable to detect ctDNA in their plasma. However, in 2 cases where we are able to sample their cerebrospinal fluid, we can clearly see this presence of ctDNA in their in the CSF. And serial monitoring of CSF in 1 patient also shown the dynamic changes in ctDNA as the patient continued to be treated with combination targeted therapy. So overall, my data has shown that ctDNA is indeed a viable prognostic biomarker. ctDNA levels at baseline can provide valuable prognostic information, but it's context dependent. It appears to be useful for treatment-naive patients, so mostly in the first-line treatment setting. The fact that ctDNA levels or patients with high ctDNA levels that are treated with immunotherapy tend to respond well to combinations of immunotherapy. There's also potential use for quantification of ctDNA as a way to stratify patients that are likely to benefit from such aggressive treatment combinations. ctDNA also has been shown to be a valuable surveillance biomarker despite our low detection rate. ctDNA was able to the fact that there's no presence of ctDNA in the beginning, or no detectable ctDNA within a 12-month period, or there's a declining ctDNA within 12 weeks of treatment, is indicative of treatment response and indicative of longer PFS. We're also able to detect PD in 62% of cases. But again, that's highly affected by a major limitation, which is the low detection rate. Now, I'd like to highlight that the results I've presented so far is based on single mutational target approach. We are now improving on our sensitivity by increasing the volume of plasma sampled, concentrating cell-free DNA to ensure maximal templating for analysis. And we're also employing multiple mutation interrogation using next generation sequencing panel. We actually redesigned our melanoma, custom melanoma panel using a hybridization capture chemistry to ensure that we can preserve and using throughplex plasma tag-seq kit to make sure that we can preserve the length of cell-free DNA fragments, and to employ a comprehensive bioinformatics pipeline with extensive error suppression and fragment size selection for improved ctDNA analysis. So with that, I'd like to thank the patients, their families, and healthy volunteers for the time, patience, and the blood samples that they've donated to our study, our collaborators, and of course the wonderful research group that I am lucky to be a part of. Thank you all for your attention.